Hello everyone, myself Preeti and my roll number is 61. My topic is corticosteroids. Adrenal gland has cortex and medulla. Adrenal cortex secretes steroidal hormones. Adrenal medulla secretes adrenaline and noradrenaline. Anatomical and functional divisions of adrenal cortex. Hormones secreted: zona glomerulosa, mineralocorticoids, aldosterone, deoxycorticosterone, zona fasciculata, glucocorticoids, hydrocortisone, zona reticularis, androgens. Main actions: zona glomerulosa, regulate water and electrolyte balance. Zona fasciculata, carbohydrate, protein, and fat metabolism, anti-inflammatory, immunosuppressant, and anti-allergic actions. Hypersecretion, zona glomerulosa, primary hyperaldosterone, zona fasciculata, Cushing syndrome, zona reticularis, adrenogenital syndrome. Deficiency of adrenal cortical hormones, chronic, leads to Addison's disease. Synthesis and release of glucocorticoids is controlled by pituitary adrenocorticotropic hormone, which in turn is stimulated by corticotropin releasing factor produced by hypothalamus. Glucocorticoids have negative feedback control on ACTH and CRF secretion. Mineralocorticoid, example aldosterone, release is controlled by the renin-angiotensin system. There is a diurnal variation in the rate of release of ACTH and cortisol, circadian rhythm. The plasma cortisol levels are highest in the early hours of morning and lowest in the late evening. The long-term use of corticosteroids in large doses will decrease ACTH secretion and gradually cause adrenal cortical atrophy. Hence, sudden stoppage of corticosteroids after prolonged treatment is dangerous and can precipitate acute adrenal insufficiency. Mechanism of action of steroid hormones. Steroid hormone enters cells of target organ, then binds to specific receptors in cytoplasm, and steroid receptor complex become activated and enters the nucleus, then binds to specific site on DNA to regulate protein synthesis, then finally response is produced. Pharmacological actions. Corticosteroid with predominant sodium and water retaining property, example aldosterone and deoxycorticosterone, are mineralocorticoids. Corticosteroid with predominant liver glycogen deposition and gluconeogenic effects, example hydrocortisone and cortisone, are glucocorticoids. The two actions, mineralocorticoid and glucocorticoid, are not completely separated in naturally occurring steroids, where synthetic preparations are available with selective action. Carbohydrate metabolism. Glucocorticoids stimulate glycogen deposition in liver and gluconeogenesis, formation of glucose from amino acids, and decrease peripheral utilization of glucose. The net result is: first, hyperglycemia; second, decreased tissue sensitivity to insulin; and third, diabetes may be precipitated or exacerbated. Therefore, glucocorticoids are contraindicated in diabetes. Lipid metabolism. Prolonged use of glucocorticoids causes redistribution of body fat that is deposited over the neck, face, shoulder, etc., resulting in moon face, buffalo hump, and fish mouth with thin limbs. Comparison of corticosteroids using hydrocortisone as a standard agent. 1. Glucocorticoids. Short acting 8 to 12 hours. First, hydrocortisone. Activity anti-inflammatory 1, salt retaining 1, equivalent dose anti-inflammatory 20. Uses and route of administration. It has a rapid onset but short duration of action. It is the drug of choice for replacement therapy in acute adrenal insufficiency. Other uses are status asthmaticus and anaphylactic shock, routes, oral, IM, IV, intra-articular and topical. Second, cortisone, anti-inflammatory 0.8, salt retaining 0.8, equivalent dose 25. Uses and route of administration. It is cheap, prodrug, converted to hydrocortisone after metabolism in liver, rarely used at present. B. Intermediate acting, 12 to 36 hours. First, prednisolone, anti-inflammatory 4, salt retaining 0.8, equivalent dose 5. Uses and route of administration. It is the most commonly used preparation for allergic, inflammatory, autoimmune disorders and in malignancies. It causes less HPA axis suppression if given once daily in the morning. Routes, oral, IM, intra-articular and topical. Second, prednisone, anti-inflammatory 4, salt retaining 0.8, equivalent dose 5. Uses and route of administration. It is prolonged, prodrug, gets converted to prednisolone in liver, less efficacious. Third, methylprednisolone, anti-inflammatory 5, salt retaining 0.5, equivalent dose 4. Uses and route of administration. It is used for its anti-inflammatory and immunosuppressant effects as high dose pulse therapy in renal transplant, pemphigus vulgaris, etc. Routes, IM, IV, retention enema in ulcerative colitis. Fourth, triamcinolone, anti-inflammatory 5, salt retaining 0, equivalent dose 4. Uses and route of administration. More potent and relatively more toxic than prednisolone. It has no mineralocorticoid activity. Routes, oral, IM, intra-articular and topical. C. Long-acting 36 to 72 hours. First, beta-methasone, anti-inflammatory 30, salt retaining 0, equivalent dose 0.75. Long-acting have highly potent anti-inflammatory and immunosuppressant effects, have no mineralocorticoid activity. Second, dexamethasone, anti-inflammatory 30, salt retaining 0, equivalent dose 0.75. Uses and route of administration. They cause severe HPA axis suppression used in allergic and inflammatory conditions, cerebral edema due to neoplasm, where water retention is undesirable, and to promote lung maturation in fetus when premature delivery is anticipated. Routes, oral, IV, IM, and topical. Local acting glucocorticoids. First, beclomethasone, anti-inflammatory positive, salt retaining nil, equivalent dose nil. Uses and route of administration. They have local action. It is used by inhalation in bronchial asthma as nasal spray for allergic rhinitis, as ointment for skin and mucous membrane lesions. HPA axis suppression is minimal. Second, budesonide, anti-inflammatory positive, salt retaining nil, equivalent dose nil. Uses and route of administration same as beclomethasone but is more potent than beclomethasone. Comparison of corticosteroids using hydrocortisone as a standard agent. Fluticasone, anti-inflammatory positive, salt retaining nil, equivalent dose nil. Uses and route of administration. It is used by inhalation for asthma and chronic obstructive pulmonary disease, orally for inflammatory bowel disease, as ointment for skin and mucous membrane lesions. Second, mineralocorticoids. First, deoxycorticosterone acetate, anti-inflammatory 0, salt retaining 100, equivalent dose nil. Uses and route of administration. It has selectively mineralocorticoid activity and is used in Addison's disease as replacement therapy. Second, fluorocortisone, anti-inflammatory 10, salt retaining 125, equivalent dose 2, uses and route of administration, has potent mineralocorticoid activity. It is used with hydrocortisone for replacement therapy in Addison's disease. Third, aldosterone, anti-inflammatory 0.3, salt retaining 3000, equivalent dose nil, uses and route of administration not used. Protein metabolism. Glucocorticoid, then protein breakdown and mobilization of amino acids from lymphoid tissue, muscle, skin, bone, etc. And muscle wasting, lympholysis, thinning of skin, loss of bone matrix, and growth retardation, wound healing, and fibrosis are also inhibited. Electrolyte and water metabolism. Glucocorticoids have weak mineralocorticoid action, cause sodium and water retention, promote potassium excretion. Thus, prolonged use of these drugs may cause edema and hypertension. The synthetic glucocorticoids, dexamethasone, betamethasone, and triaminoxylone, have no sodium and water retaining property. Calcium metabolism, anti-vitamin D action. Prolonged use of these drugs may lead to osteoporosis and pathological fracture of vertebral bodies. Glucocorticoids increase renal excretion of calcium and inhibit calcium absorption from the gut, which decreases blood calcium level. Glucocorticoids inhibit osteoblast bone forming cells and stimulate osteoclast bone resorption cells. Cardiovascular system. Glucocorticoids have sodium and water retaining property, exert a permissive effect on pressure action of adrenaline and angiotensin. On chronic administration, these drugs may cause hypertension and worsening of congestive cardiac failure. Skeletal muscle. Corticosteroids are required for the normal function of skeletal muscles. Weakness occurs in both hypocorticism and hypercorticism. Muscle weakness and fatigue in hypocorticism due to inadequate circulation and in hypercorticism due to hypokalemia. Prolonged use of glucocorticoid may cause muscle wasting and weakness. Central nervous system. Corticosteroids have a number of indirect effects on the CNS through maintenance of blood pressure, blood glucose concentration, and electrolyte levels. They also have direct effects on the CNS and influence mood and behavior. Patients with Addison's disease show depression, irritability, and even psychosis. On the other hand, glucocorticoid therapy can cause euphoria, insomnia, restlessness, and psychosis. Gastrointestinal tract. Glucocorticoid inhibit PGs, which increases gastric acid and peptic secretion, may aggravate peptic ulcer, and inhibit PGs decrease local immune response against H. pylori. Blood and lymphoid tissue. Glucocorticoid therapy leads to a decrease in the number of circulating lymphocytes, eosinophils, basophils, and monocytes. This is due to redistribution of cells. They have a marked lympholytic action, therefore are used in lymphomas and leukemias. Anti-inflammatory effect. They have powerful anti-inflammatory and immunosuppressant effect. They prevent or suppress the clinical features of inflammation such as redness, heat, pain, and swelling. At tissue level, they suppress the early phenomena, capillary permeability, edema, cellular infiltration, and phagocytosis, and late responses like capillary proliferation, collagen deposition, fibroblast activity, and scar formation. Glucocorticoid leads lipocortin, which give phospholipase, which help in conversion of membrane phospholipid to arachidonic acid, which gives cyclooxygenase and lipooxygenase, in which cyclooxygenase give PGs and lipooxygenase give LTs. First, glucocorticoids induce a protein called lipoprotein which inhibits phospholipase A2. Hence, PGs, leukotrienes, and PAF are not formed. Second, production of cytokines like IL-1, IL-6, and TNF alpha necessary for initiating inflammation is inhibited. Third, glucocorticoids stabilize lysosomal membrane and prevent release of inflammatory mediators. Fourth, glucocorticoids inhibit production of various adhesion molecules from endothelial cells and macrophages, which decreases leukocytes migration to site of injury. Immunosuppressant effect. Immune response leads to T lymphocytes and B lymphocyte, in which T lymphocyte, then lymphokines, then cell-mediated immunity, and in B lymphocytes, immunoglobulins lead to humoral immunity. Glucocorticoids have immunosuppressant effect. They inhibit both B cell and T cell lymphocyte function, and this results in impairment of humoral and cell-mediated immunity. Cell-mediated responses may be inhibited indirectly by inhibiting the production of cytokines, including TNF-alpha and interleukins. They also suppress all types of hypersensitivity or allergic reactions. Adverse reaction. A single dose of glucocorticoid is practically harmless, rather they are life-saving drugs in conditions like anaphylactic shock, acute adrenal insufficiency, etc. The use of glucocorticoids in supraphysiological doses for more than 2-3 weeks causes a number of undesirable effects. Most of the adverse effects are extension of their pharmacological action. First, metabolic effect. Hyperglycemia, precipitation of diabetes mellitus, or aggravation of pre-existing diabetes. Second, Cushing habitus. Abnormal fat distribution causes peculiar feature with moon face, buffalo hump, and thin leaf. Third, gastrointestinal tract. Peptic ulceration, sometime with hemorrhage or perforation. Fourth, salt and water retention. Mineralocorticoid effect may cause edema, hypertension, and even precipitation of CCF, particularly in patients with primary hyperaldosteronism. This can be minimized by using synthetic steroids like dexamethasone, betamethasone, etc. Fifth, muscle. Steroid treatment can cause hypokalemia, leading to muscle weakness and fatigability. Long-term steroid therapy leads to steroid myopathy. Sixth, bone. Osteoporosis with pathological fractures of vertebral bodies is common. Ischemic necrosis of femoral head can also occur. 7. Growth retardation in children is more common with dexamethasone and betamethasone. 8th, eye. Glaucoma and cataract may occur on prolonged therapy. 9th, central nervous system. Behavioral disturbances like nervousness, insomnia, mood changes, and even psychosis may be precipitated. 10th, long-term therapy with steroids lead to immunosuppression, which makes the patient vulnerable to opportunistic infections like fungal, viral, bacterial, etc. Inhalational steroids can cause local irritation and fungal infection of upper respiratory tract, which can be irritation and fungal infection of upper respiratory tract, which can be prevented by the use of spacer and rinsing the mouth after inhalation. 11th, hypothalamic pituitary adrenal axis suppression. The most dangerous side effect of long-term steroid therapy is HPA axis suppression. Therefore, important precautions to be taken during long-term steroid therapy are: whenever possible, topical use is preferred. Short or intermediate acting steroids, hydrocortisone, prednisolone should be preferred. Give steroid as a single morning dose at 8 am if the daily dose is high. Administer two-thirds of the dose in the morning and one-third in the evening, which will mimic endogenous hormone levels and minimize chances of HPA axis suppression. Try alternate day steroid therapy in chronic conditions like bronchial asthma, nephrotic syndrome, systemic lupus, erythematosus, etc. Withdrawal of steroid after long-term less than 2 weeks treatment should be very slow to allow recovery of normal adrenocortical function. The doses of steroid should be tapered gradually. Abrupt stoppage of glucocorticoid therapy following prolonged use leads to flaring up of the underlying disease being treated. Withdrawal symptoms like fever, myalgia, arthralgia, malaise, etc. Acute adrenal insufficiency on exposure to stress, which manifests as anorexia, nausea, vomiting, abdominal pain, hypotension, dehydration, hypoatremia, hyperkalemia, etc. Therapeutic uses of glucocorticoids. Replacement therapy. First, acute adrenal insufficiency. It is a medical emergency. It is treated with hydrocortisone and normal saline with 5% glucose to correct fluid and electrolyte imbalance. Precipitating causes such as trauma, infection, or hemorrhage should be treated. Second, chronic adrenal insufficiency treated with oral hydrocortisone. Two-thirds of the daily dose is given in the morning and one-third in the evening, along with adequate salt and water. Third, adrenogenital syndrome and adrenal varlism. Corticosteroids are helpful. The beneficial effect is due to suppression of pituitary ACTH, which in turn reduces adrenal androgens. A highly potent glucocorticoid like dexamethasone is preferred. Non-endocrine disease. Corticosteroids are an important group of drugs used clinically in a variety of diseases. Because of their dramatic symptomatic relief, they are often misused. Non-endocrinal disease require supraphysiological doses of steroids. The beneficial effect of glucocorticoids are mainly due to their anti-inflammatory and immunosuppressant effects. First, rheumatoid arthritis. They produce an immediate and dramatic symptomatic relief in rheumatoid arthritis, but they do not halt progression of the disease. Intra-articular injection is preferred only if one or two joints are involved. Steroids can be given as adjunct to non-steroidal anti-inflammatory drugs and disease-modifying anti-rheumatic drugs. Second, osteoarthritis. They are rarely used in osteoarthritis. Intra-articular injection is recommended for acute episodes. Third, rheumatic fever. Glucocorticoids produce more rapid symptomatic relief than aspirin and are indicated in cases with carditis and CCF. Prednisolone is given along with aspirin and should be continued until the ESR comes to normal, then the steroid is tapered off gradually. Gout. They are reserved drugs in acute gout when it is not responding to NSAIDs. Fifth, allergic diseases. The manifestation of allergic disease such as hay fever, reaction to drugs, urticaria, contact dermatitis, angioneurotic edema, and anaphylaxis can be suppressed by glucocorticoids, but they have slow onset of action. Hence, severe reactions such as anaphylaxis and angioneurotic edema require immediate therapy with adrenaline. In hay fever and mild allergic reaction, antihistamines are the preferred drugs. Sixth, bronchial asthma. Glucocorticoids have anti-inflammatory and anti-allergic effects. Hence, they reduce mucosal edema and bronchial hyperreactivity. They help to prevent and reverse tolerance to beta 2 agonist. In acute severe asthma, hydrocortisone is given along with nebulized beta 2 agonist and ipratropium bromide. If a chronic asthma needs steroid, it is better to give inhalation preparation like beclomethasone, budesonide or fluticasone because they cause minimal systematic adverse effects. Seventh, collagen diseases such as polymyositis, polyarthritis, nodosa, polymyalgia, rheumatica, and dermatomyositis can be controlled with large doses of glucocorticoids. Steroid with negligible salt and water retaining properties preferred. 8th, renal disease. Glucocorticoids are the first line drugs in nephrotic syndrome. Ninth, ocular diseases. They are frequently used to suppress inflammation in the eye, thus prevent damage to vision. Agents may be administered topically, subconjunctively, systemically, or by retrobulbar injection, depending upon the condition. Steroids are contraindicated in herpes simplex, caries, and ocular injuries. 10th, skin diseases. Glucocorticoids dramatically relieve itching, pain, and inflammation in allergic and other dermatoses. To minimize systemic effects, topical steroids are preferred. Systemic steroid therapy is needed in severe conditions like exfoliative dermatitis, dermatomyositis, pemphigus, etc. Psoriasis, keloids, and hypertrophic scar are sometimes treated by intralesional injection of steroids. 11th, hematological disorders. Autoimmune hemolytic anemias usually respond to glucocorticoids. Because of their lympholytic action, glucocorticoids are used to treat certain malignancies, leukemia, lymphomas, Hodgkin disease, multiple myeloma, etc., usually in combination with anti-neoplastic drugs. 12th, cerebral edema. The effectiveness of glucocorticoids in cerebral edema depends upon the underlying cause. They are very effective when the edema is caused by brain tumors, metastatic lesions, and tubercular meningitis. They are least effective when the cerebral edema is due to head injury. A steroid without salt and water retaining activity, dexamethasone, is preferred. 13. Intestinal diseases. They are used in ulcerative colitis when the patient is not responding to other forms of treatment. Methylprednisolone can be administered as retention enema during acute episodes. 14. Shock. Prompt intensive treatment with glucocorticoids may be life-saving in septic shock. 15. Organ transplantation. Glucocorticoids are used to prevent as well as treat graft rejection. 16. Hypercalcemic of malignant disease, sarcoidosis, and vitamin D intoxication response to prednisolone. 17. Other uses include Bell palsy, acute polyneuritis, and myotonia. 18. Dexamethasone can be used to test the hypothalamo-pituitary adrenal function. Relative contraindication for the use of corticosteroids: hypertension, diabetes mellitus, peptic ulcer, tuberculosis, herpes simplex keratitis, osteoporosis, epilepsy, psychosis, congestive cardiac failure, renal failure, glaucoma.